Good evening, I am Rita Kanya. Now, according to the Uganda Demographic Health Survey 2016, 4 in every 100 teenage girls are either pregnant or have had their first child here in Uganda. The 2016 study on the linkage between pregnancy and school dropouts in Uganda, carried out by the Ministry of Education and Sports and the Forum for Women Educationalists Uganda, found that among sexually active girls, 36%, 29% in the primary and 50% in the secondary school have used contraceptives. Over the 2/3 of sexually active girls in primary school got pregnant. Now, such figures are worrying, but given that we're going through a pandemic, these figures have only increased, and there are adverse effects of this. Now, the Ministry of Health Uganda, in collaboration with the Youth Focal Point 2020, the Uganda Youth Alliance for Family Planning Adolescent Health, with funding from the UNFPA, have developed the Google Contraceptive Maps with an aim of increasing access to their knowledge and the services, and that is about the availability of the desired reproductive health commodities, especially contraceptives, of their own choice from their nearest health facilities. Now, all of this is new to you. A few things I might have said you have heard before, but I'm not going to be the one having a conversation. I'm only the moderator this evening. Joining me to have this conversation and the launch of the Google Contraceptive Maps, I am joined by Dr. Robert Mutumba, who is the Principal Medical Health Officer in the Reproductive and Infant Health Division at the Ministry of Health. Good evening and welcome, Doctor.
Yes, good evening.
Next to him, on his left, is Phyllis Patience Nanyondo, who is the Project Officer at the Uganda Youth Alliance for Family Planning and Adolescent Health. Good evening and welcome, Phyllis.
Thank you, Rita. Good evening, everyone.
And the last lady who will be joining this panel is Anne Alan Sizomu, who is the Program Specialist, Adolescent and Health SRHR at UNFPA. Good evening and welcome.
Good evening.
Now, we'll start off this conversation by the figures I mentioned earlier were from 2016, a study done in 2016. But where do we stand as a country? To give us a bit of a picture, paint that picture for us, Dr. Robert, tell us what the crisis, when it comes to the current contraceptive crisis within the country, looks like.
Yeah, thank you, Rita, and to everyone who is watching and listening in. Currently, looking at the contraceptive picture in the country, especially focusing on the young people, we see that the situation has been worsened by the COVID-19 pandemic because in the recent Performance Monitoring Action 2020 report, we see that roughly it's about 4 out of 10 young people, particularly aged between the 15 to 24, that were able to receive what we term as a modern contraceptive method. So 4 in 10 is really on the lower side. Much as progress has been made, roughly in terms of target, we had targeted to see that at least half, 50%, of those who are actually in union but willing to use a modern contraceptive method are able to access and use the method. But of course, the picture is that you know what happened since March 2020 when we got into the C-19 pandemic crisis, and then we had lockdowns, and you see that being in school, for example, for the young people, is a protective factor. And so because many of these young people were out of school, we saw the churches and the mosques, the religious settings also being closed. So we see that access also to health facilities became quite complicated. Many of the young people, but also the largely women of the reproductive age, 15 to 49 years, were not able to access these contraceptives, even when they were available in stock at the health facilities. And so for the young people, we are seeing an increasing trend in the teenage pregnancy rates. So it is during this period that we have noted the highest ever prevalence of young people who are getting pregnant. And so when we talk about a crisis, for me, I think the epitome of this crisis is largely the pregnancy, the abnormally high rates of pregnancy rates. So in the year 2016, according to the Uganda Demographic Health Survey, 25% of the adolescents were pregnant. So we will be having our next demographic survey, I think mid this year, 2021. We'll see where we will be standing as a country. But from the look of things, I see that this particular year of 2020, where we've had lots of teenage pregnancies reported, might probably undermine some of the efforts that we have undertaken. But of course, a number of measures have been put in place. But also in terms of what has escalated the crisis, again, it's the aspect of lack of access to the age-appropriate or the developmentally appropriate information and education for these young people regarding their sexual and reproductive health. So you see that as a country, a number of teams have largely been trying their best to engage parents, but also the other stakeholders, to see that they speak to their young people about issues of their sexual and reproductive health. This has been a gap, and it remains a gap even before the pandemic, but also currently you see that this, as a country, I think we need to have some sort of a cultural shift. People living in other parts of the world, there are some other settings where I think it's pretty much easier for many of these parents to freely interact with their young people and speak to them. And the fact is that if as parents we do not speak to our young people, someone else will speak to them. And so we recently undertook what we term as a regulatory impact assessment to really understand the issues around young people. But the main issue that really came up from this is really the issue of lack of this information. Many of these young people are ending up getting pregnant, contracting STIs, and also abusing substances, largely because of the breakdown of the support systems right from the family. Ideally, it's the parents that should take the primary responsibility to speak to these young people. But then in addition to other social structures like the churches and the mosques, and then later also other support structures within the community. So in terms of the crisis, largely it's also been hinged on the lack of access to these age, but also developmentally appropriate information. But also in addition, there are issues of cultural norms, unfavorable cultural norms, myths, and misconceptions. So many young people have so many myths around their sexual and reproductive health. And all this is fueling this crisis that we are seeing. So for the contraceptives, I think as we continue to discuss, even in this morning we're listening in, we had a working group and we are listening to the stock status regarding the reproductive health commodity status. But we are glad that the Ministry of Health, Government of Uganda, with support from a number of partners, UNFPA, USAID, DFID, UNICEF, have really done their best to ensure that the country really has adequate stocks of contraceptives. Mm-hmm. So you could see that the stock levels are not worrying, but the challenge is actually now the demand, people coming up to be able to utilize some of these services. Right. Thank you.
Thank you so much, Dr. Robert. Now, Anne and Phyllis, just to bring into the conversation, we'll start with you, Anne, and come to you, Phyllis. We listened to Dr. talk about the issue being lack of information, lack of knowledge, lack of access, but the contraceptives are there. And I believe you interact with adolescents and the youth on a day-to-day basis in different places with UNFPA. Do you agree with him? And where do you think, when it comes to the crisis of contraceptives within the country, what is your take on it?
Thank you. I think I agree definitely with Dr. Mutumba, because as a ministry, the coverage is all over the country. So as a ministry, there's the overall picture. To supplement on what he said in terms of the challenges, or the situation that we are in terms of the crisis. Of course, given the pandemic just hit us in a way that even we're not prepared in terms of the scale of the pandemic, and the interruption. Because the structures were within, a certain range that we can deal with some bit of the epidemic, and sometimes in particular situation. But now, in this case, it's on a large scale. What happens is that some of the challenges, like what you said, is that the issue of the access. It's not just, I think, the information. In this case, where there was the access is also being limited by the issue of the high transport costs, because then you'd find that some of the young people, the challenge was, how do they move to the nearest health center? So even if some of the contraceptives were there, the issue of then the access became an issue due to the geographical either location, but at the same time the cost associated with the distance. And one of also the other thing which is being worked on, but still it's an issue, is that the issue of information is very important, as well as the issue of then the training of the health workers to be youth-friendly to deliver the service. Because a young person may have the information, but when they reach a health facility, and then you find a provider who is not friendly or giving all the information, or the health facility doesn't promote issues like of confidentiality, like if I go, then I meet a neighbor, then I meet, my mother or father's friend, or an elder. They're going, what are you doing here? How is your mother? How is your father? So that conversation, and sometimes because the young people would prefer privacy, just like sometimes also us, even adults, you don't want to go and then you actually disclosing all this info. So within that, there are certain standards and challenges that also come in terms of the access that prevent young people from accessing the contraceptives. And some of those challenges, which he has also hinted on, are the issues also of that have to do with cultural norms. I think we still are not there in terms of breaking those barriers, of saying, can we give young people information in a comprehensive way so that when they are faced with a challenge, they will make the right decision regarding the contraceptive choice or protection. But what happens is that most of the times in the side, we think giving the young people the information promotes sexual activity, promiscuity, and all that. What we're saying is that it's time to come together and then have a conversation where we're saying what can be packaged from the religious angle, because what we're tackling, all of us, is that no one wants the teenagers to get pregnant. No one wants it. So if we come from that point of no one desires that, the question then will be, what can everyone do within their mandate and within their structure in order to ensure that the young people actually do not get unintended or unplanned pregnancy. And then the teenagers are allowed to, to experience what it means to be young and not to be a parent. Yeah.
We have one of the young people who is also a project officer with UAFPA. So from you, Phyllis, you can tell us your experience, because I believe you can be able to show how it is on a day-to-day basis speaking to the youth.
Yes.
And also, I don't know if you have had access to these services. What is it like? Because when Anne mentioned, and also Dr. Robert mentioned, one, the age-appropriate services, two, the friendliness when they get to these particular health centers or health services that they seek to find. What is it like?
Well, when we look at the perspective of going to a facility and you want to be able to get a method of your choice. For example, let me say I've gone to one facility and you'd like to get, for example, an implant. So you go and approach this nurse and you ask her about it. How does it work? And then, first of all, her attitude alone will set the continuation of the conversation. Once I approach you and you're really, okay, some shout, some are rude, and then you ask yourself, why are you being rude to me? I'm only seeking for family planning services. I only want to know whether the implant is the right one for me. So that attitude alone has really distanced the youth from accessing those commodities, and also the time taken to be able to find out whether a contraceptive method I need is available at this facility. I might go to one and they do not have, for example, a female condom, and yet it is what I want. So those challenges come in a way that they are not favorable, and if I know that this day has come and I want to get family planning on this day, and then I go to the facility and they do not have it, then I lose morale. I do not go back. But then again, we need to be able to make it wide enough for one to not bounce, in order to be able to know that if I go to this hospital, I know they have this and this and this, and I'll get it at what I want. Yes.
Well, Doctor, from what Phyllis is saying, you mentioned the working group that you had earlier on today. Conversations, how would a health worker, one, are they trained to say who can we allow to have these particular contraceptives, and where do they know when to draw the line? Who sets the line for them? That, no, if you're below this age, I'm sorry, I can't give you this.
Okay, so access to family planning commodities, or what determines what type of contraceptive you eventually receive is a decision of the recipient or the client. So what normally happens is that a health facility is supposed to ensure that they are well stocked with the wide range of contraceptives. So the facility should be able to correctly, and again, this is what we are supporting teams to do, correctly quantify their needs in terms of the various contraceptives, the pills, the injectables, the implants. So, but the decision whether you're a young person aged 18, 19, or 20, or you're a 40-year-old, on which contraceptive method you're going to take up, largely is not made by the health worker or the provider.
Does the health worker know that?
Rather, the health workers are meant to have a comprehensive knowledge to provide what we call a method mix. So again, this is what we are doing. We are undertaking a number of trainings on method mix and supporting facilities to, one, the providers to be able to have this comprehensive knowledge. And so rather than having just a knowledge on, let's say, insertion of implants, administration of giving pills or IUDs, And this also is still a challenge in a way, the issue of method mix, but also in terms of the provider knowledge. We've noted with great concern that if a health worker has skills, for example, in prescribing pills and implants, most likely operational studies show that that's what is more likely to bias the client. But rather what we are doing is to ensure that that one health worker is sort of all round in terms of should be able to insert an IUD for a client who has made a decision to use the IUD, but rather not to determine what type. So what health workers are supposed to do is to give that effective counseling, but the decision, sometimes they guide based on the criteria. For example, the IUD, there are a few clients who may not be eligible ideally to use the IUDs. So the health worker could be able to give guidance in such a situation. But otherwise, for the method, the choice is made by the client.
Okay, from what all three of you have sort of mentioned is the culture, the society that we live in. We're having a conversation about contraceptives and we're putting young people in that sentence when it comes to access to contraceptives. And many might be saying, are we sure we should be having this conversation? There's a bit of a hesitation. But to talk about a change in mindset, from the three of you, we'll start off with you, Anne. The need for a change in mindset before we can go ahead and talk about the theme, mapping out our future amidst the crisis times and what we now need to be looking at. Talk about why our mindset needs to change, the need for it to change, and where it might be lagging.
I think the issue of the mindset, or what we would call the attitude change, needs to change based on the evidence that is available to us through, global studies, but also through national or studies at at the district level. We have statistics, and the picture when it comes to teenage pregnancy is not good. There are also studies that actually give evidence in terms of the cost. How much are we losing if we have 1 in 4, teenagers getting, pregnant? Yeah. What does that also mean in terms of it has the economic burden? It means that girls will not realize their full potential because opportunities, when you drop out of school at 13, 15, it means that the opportunities you would have are limited in terms of economic and also realizing your dreams and what. So based on that, we see that that evidence should be, one of the guidance in terms of why we need the attitude change and, openness to really seeing what is available, and also, learning. There are things different, either the learning can be across, the districts that are doing well. So there's also local learning. There's also learning, from neighboring countries or globally, how have people been able, or countries, to really have programs that have led to, reduction in teenage pregnancy or models of reaching young people. Also, when it comes to really young people, the issue of innovation becomes very, very key because generations keep changing. What was maybe viable or something that worked 10 years ago, 15, may not be sometimes applicable currently. That's why for us, we working closely also with the ministry and some of the youth or youth organization to ensure that we find out how would young people want to access information. So there are things like, for example, during this, this crisis, things like having like an e-shop, through by partnering maybe with like Jumia, so that the person can order for contraceptives and delivered, even a young person, because they may have a mobile phone and all they need is actually to go order, and then it can reach them, you know, wherever they, the service can reach. Such things create, you know, create opportunity. In some of the places with the Ministry of Health are things like a voucher system and other partners where young people who would ideally not be able to afford are able to really ensure that there's that opportunity. And also for those who are pregnant, they're able to access service. Because I think teenage pregnancy is not just about, you know, assuming that every teenager who gets pregnant will actually, you know, carry the baby to term. And there are so many complications. It has also to do with death. So it's also saving the, you know, the life of this teenager. So it's not, those are some of the conversation that should be able to, you know, need to happen. And it changes because young people would also prefer to get information from the parents, trusted teachers, and some of this conversation, we need also to look at reports that are coming in. We realize that some of these young people, it's not the attitude that they went out there and it's because they are bad teenagers. They brought it on themselves. We're having a crisis of a lot of sexual abuse in the country through the police reports. We can see that, and some of like the hotlines where, you know, cases are reported, and we see that increase. And then within that, you realize the trend of the sexual abuse happening, it's not usually by strangers. It's by relatives, it's by teachers, and people who are trusted, then, you know, other maybe random strangers. So you find that if we're not having a conversation, then how are we protecting especially the teenagers to be able to trust a teacher under their care, a relative who they, you know, go and visit or, you know, share maybe a home with and all these other things. So I think it's very important that some of these should be what is happening also around us should be able to guide that we're better off having the conversation in terms of how do we package, how do we deliver, rather than saying it's a, you know, it's a no-go area. We don't want to discuss about this because that has gone on for long, and we're seeing that the statistics, as Dr. Mutumba has pointed out, is not changing. So if something is not changing, it means that we need to find ways of ensuring that we do things in a different way for us to realize the desired change.
Okay. Well, Phyllis, you on an end have conversations with adolescents, with the youth, having conversations to do with sexual health and reproductive rights, the access to them. As Anne had mentioned, it shouldn't be a no-go area, but to tell someone that if you change your mindset, it's not that if you have these conversations about contraceptives, you're sending them out to do these things that will lead them to have pregnancies and become teenage parents. Talk about if you empower a teenager with this information, if you empower an adolescent with this information, how then does it change their future?
Thank you so much, Rita. When we empower the youth with the information about these services, first a youth will be able to know what's good for them. They will know that if I can be able, for example, if one is still at school or still at campus, he or she will know that let me first concentrate on my books, at least let me get a degree, or at least let me be able to get a job so that I can be able to go in for a child. But for now, let me sorry, for now I can be able to get the information about these services and then go for them. You know, so that one can be able to really map their future well and also get to know the right things for themselves. Yes.
Doctor, when you mentioned earlier on age-appropriate information, age-appropriate services, just touch on that, because as we get into what particular services are being offered, when we go into the Google Contraceptives contraceptive map, what exactly would I tell my 13-year-old, or what exactly would I be taking them to get from a particular health center?
So thank you. Again, that's usually a sticky part of a discussion when we talk about age or developmentally appropriate. So a 16-year-old or a 17 or 18-year-old, you may not there's a conversation that you may have with a 15, 16, 17 or 18-year-old that you may not have with an 11-year-old. And so when we talk about age appropriate, it's also informed by their development milestone. There are things they will be able to appreciate, things that will make sense to an 11-year-old that may not make sense to an 18-year or a 17-year-old. And so that's why for now, I cannot be able to disaggregate that this is information for an 11-year-old, this is for 15. But this information has already been disaggregated. And why we do that is because, again, it's in line with their stages of development. And so, but there is a discussion that you should have with a 16, 17, 18-year-old. That may really not make a lot of meaning with a 10 or 11-year-old.
Okay. Well, getting into what you see at the bottom of the screen, the theme, which is mapping our future amidst the crisis times, having a conversation, and you might have heard a number of times people say, Google is your friend. For so many things, Google is our friend. But taking a look at what we're having the conversation, the Google Contraceptive Maps and the launch of it, starting with you, Phyllis, the innovation that UAFPA has come up with in this particular area. Take us through it. Why the Google Contraceptive Map, and how did it come about?
Thank you, Rita. Allow me to take you back in March 2020. When there was lockdown, so many people thought of what next. And there came the rise of the internet, where so many people went to the internet to be able to do their work, especially. And now, when we looked at that, and we looked at the youth of today, most youth at least have a smartphone, and they can be able to access the internet. And now we decided to come up with a way a young person can be able to access the services and the information on their smartphone. That's the Google Maps. Now, these maps are divided in divisions, and we basically looked at the youth in Kampala, especially in the Kawempe, Makindye, and Nakawa division. So any youth within those divisions can be able to go to their smartphones and then type in the Google contraceptive availability in any of those 3 divisions, and then the map will come and they'll be able to see the health facilities, and then they'll be able to see the products and the services as well. Yes.
All right. Well, Dr. Mutumba, representing the Ministry of
Yes,
Health, which is
yes.
in collaboration with UAFPA, what services, if I now know my child might have a smartphone and could be able to access this, what services would they be able to access?
So thank you. In regards to what has just been mentioned, so when you move to these facilities, so you expect to find a wide range of contraceptives. And again, like I earlier mentioned, with provision of contraceptives, the key guidance is a method mix. So unless there is an event of a stock out, we expect that these facilities are well stocked with the entire wide range of modern contraceptives. So you expect to find pills, injectables, there are those that we term as implants, then intrauterine contraceptive devices, call them IUDs. And then there are also a number of we also expect, first of all, to receive adequate or effective counseling before you actually make a choice of which method you're going to use. And I re-echo this, that the health worker does not make a choice for you. What they only do as experts in that area is really to guide you. For example, if I'm a, let's say 24-year-old, and I need to have to delay pregnancy, I need to have my next child after 3 years. But you're asking the health worker to probably consider giving you pills. The health worker actually might guide that since you actually need to have your next pregnancy after 3 or 4 years, probably you might benefit better from a longer term method, because why should you be swallowing pills for 3 years when an implant? So that's the only way they come in to give that expert guidance. But even when you insist, they still can't, the choice still remains yours. But the other thing I wanted to bring up in that regard for people who could be watching this, probably people would be asking, looks like this Google Map app is targeting, urban young people, literate urban people, and, yeah, true. In terms of interventions, you can never have one intervention that would target everyone. But what we are doing is really to, one, map up and understand our population. So, for example, we have the rural young people in the rural areas, young people in the urban areas. But even in Kampala, we still have urban and rural.
We also have those who don't have that smartphone to
Yes,
access the Google.
yes.
So how then do I access these services?
So this particular intervention is actually targeting those that are able to access. So, but we also have a mixture of interventions for even other categories of young people. So for this particular one, I was also very impressed to hear of this upcoming innovation. And so for this particular segment of the young people, I think this is really something great. We are looking out to seeing results out of this. But we really encourage, especially those who are able to access the internet, to be able to. I know that I'm also trying to understand details regarding this app, but I know that when you log in, you're able to have a feel of which, for example, contraceptives are available, so that you do not bounce. And again, one of the major limitations that we've had with contraceptives, not only young people, is when a client works at a facility, take them through the counseling, and then they realize that what they need to take up is an implant. But now, at that discussion, when you're about to conclude, then the health work is like, oh, the implant is out of stock, you'll come back tomorrow, you get. So it really becomes a setback. And accessing a contraceptive has never been an emergency, except in situations where people come in seeking for emergency contraceptives. But routinely, if somebody comes in and, is willing to take up a method, and you tell them they're out of stock, and then come back tomorrow, most likely, the other day, they'll just come back when they are pregnant. So I think the beauty with this app also is to ensure that a young person doesn't show up and bounce at a facility, but they are able, I think, to tell in terms of what some of these available contraceptives are. But largely, the issue of first deeply and getting adequate information about this wide range of contraceptives, but also being able to receive the guidance to make choices is something that is very key in this.
Okay.
Thank you.
Well, UNFPA, as a founder and representing UNFPA in this particular conversation, why the interest in this one, and where do you see it going in this particular innovation?
I think the ministry is there, can answer, because we we do this closely, being our mandate is that really we support what is within the government of Uganda, and in this case Ministry of Health needs, and innovation is one of the things that we're really passionate about, especially when it comes to young people, because there's no one size fits all. During this pandemic, we talked about issues like safe border, delivering, condoms, or partnership with Jumia, where now you can go to the e-shop and pick the, order, contraceptive, like how you would be. So you could be doing your shopping, for baking pans or or sugar, and then you say, yeah, I need my refill, you do that. So it's also about convenience and the fact that we need to look at young people in their uniqueness, because access also differs. For example, if we're dealing with the young people, let's say in a humanitarian setting, like in West Nile, Northern Uganda and all that, some of these may not be, maybe the best way to reach, but you'll find that with Ministry of Health and other partners, there's a lot of outreaches that have been happening within the, humanitarian setting to ensure that we reach we reach out to the, the young people who are refugees or living in refugee settlements. Because of the situation, it may not be that, they're moving to this place or this place because they're in a new environment, new community. So you find that taking also services closer to, to young people, even within the pandemic, has also been a very good, way in terms of ensuring that the service continue despite, the lockdown, and the ministry has been able to really continue with that, and the young people have access, services within the outreach setting and all that. So I think being able to continuously innovate to reach different young people in different circumstances and geographical area and within their different tastes becomes, it should be part and parcel of our openness to ensure that we innovate, we try out. If something works, we scale up, things like that, rather than saying that it's one size fits all. So if this is outreaches work best maybe for this community, we don't need to stop. We should continue. If the Google, map and what I can be home as a young person, I look, I'm like, I'm in Kawempe, so let me do, or today I've actually come to town. Instead of Kawempe, they know me, I can as well go to, to this division. Then you can easily tap in and go to that instead. And this also means that with the generation of evidence and how it's working and all that, the ministry then can be able to decide, do we scale this up in urban centers and what? So I think the issue of the monitoring, of seeing how this works and how young people are taking it up is also part of the learning curve. Yeah.
All right. For the young person who's listening and watching and saying, oh, maybe I should try this, the Google Contraceptive maps. Phyllis, just take us through, take them through, actually, not us, but them who are listening and watching. How would they be able to access this? I have my smartphone, where do I go?
Okay.
Step by step, yeah.
Okay. For a young person watching and one who has a smartphone, you get your smartphone, open the Google Maps application, and then you'll simply type in contraceptive availability in Kawempe division.
If
that
you
is
are in
Kawempe, yes. And one in Nakawa, contraceptive availability in Nakawa division, and the same for Makindi division, yes.
Okay, and then they can be able to know the next step.
Then the next step, so if you're in Kawempe and you've put in contraceptive availability in Kawempe division, it will bring you our map of Kawempe division. And in that map, you'll see icons of H. And when you tap on those icons, it will bring the name of the health facility. So you'll go down, you'll read the name of the facility below on your smartphone, and then you'll click in that name, and then you'll see the products and the services below. Yes.
All right. Well, if you're in Makindye, Kawempe, or Nanakawa divisions, and you have your smartphone, you have access to these particular services. Your parting shots, Doctor, and over to you, Anne.
Okay, so thank you so much. One, as we conclude, I would like to re-echo the fact that, one, we need to have a culture shift in terms of the way we think about the young people. One, the statistics are speaking every day that we have a serious issue, the issue of the high rates of teenage pregnancy. And when you look at last year's annual death report on why mothers and babies die in the country, you see that 1 in 3 of the mothers who are dying are actually classified as young people. Mm-hmm. So they contribute a significant portion of the maternal deaths that we have. And so we need to do our very best, working together. Again, with using, undertaking that multi-sectoral approach, we all need to work together. The Ministry of Education, I'm glad we are working more closely with the Ministry of Gender. Some people term it as a ministry of everyone. And the Justice, Law and Order sector. And we are glad and we appreciate the development partners and implementing partners for the support in terms of ensuring contraceptive commodity security for the country. We appreciate. Government is also gradually increasing commitments in terms of budget allocation for commodities, reproductive health commodities. And the other aspect really is for us to see how best we engage parents as a first line level of, providing this information to the young people so that they get better prepared to face more challenges in life. So in conclusion, it's really an issue of us working together. One ministry alone, Ministry of Health alone, cannot be able to avert all these crises, but with commitments, we are glad and happy that the leadership at all levels, the President has made commitments, the ministers, but also the entire political leadership, but also the leadership at the Ministry of Health is also very committed to ensuring that issues of adolescent and actually school health are well addressed. I know you're aware that 1 year ago is when we had the adolescent and school health division also created. Yes. And that's the first clear sign that shows that the leadership is really very committed to ensuring that issues around adolescent and young people's health are a top priority.
Okay.
Yeah.
Well, before we get to you, Anne, Doctor, will we be seeing more of these in different areas? Because if we're just saying the 3 of them, some might be saying, when will it come to our end? So do you think we'll be seeing more of these?
The Google Map?
Yes, the Google Map.
So for the Google Map, like any other initiative, initiatives or innovations, usually when you're trying out something like she mentioned, you don't want to try it out at a full scale. But for you actually want to try it out. So in these 3 divisions, we'll be learning. Young people will be giving us feedback on how best we can improve this application. And I think once we address all if there are any issues, then we'll be able to see how to get it scaled up, but also after addressing any emerging issues around the use of this initiative.
Okay. Yes. To you, Anne, your parting shots.
Thank you very much. I would say that one thing that for the leadership of Ministry of Health and being open to really innovations around reaching young people. What Dr. Mtumba said, the issue of young people is multi-sectoral, and if you really to work at realizing the full potential and taking advantage of also achieving the demographic dividend, we need to really invest in young people, but at the same time be able to ensure that we do what we can to help the young people realize their potential, by ensuring they stay in school longer, they do not get pregnant earlier due to the complications, as well as the fact that we are losing a very good resource prematurely. So this means that we need to still continue to engage with the religious leaders and cultural leaders of faith-based institutions, which we're doing as a UNFPA through the government partners or like a national planning, a National Population Council, leading on different aspects and working with the Ministry of Education, seeing how is sexuality education rolled out within the Ugandan context, and Ministry of Gender, how can we reach parents and communities still in the context of Uganda, and what is within the guidelines. And I think the other thing which is also very key, we have so many policies that are in place and can actually, guide, or some that are pending, approval. It's also very key that those good policies are given a life in terms of the implementation, so that service providers and different stakeholders can engage in terms of the rollout and ensuring that the young people actually benefit, and most importantly that these young people involved right from the beginning, and they're allowed to share their their views and aspiration, because we cannot program for young people without young people. So we need to engage, and we need to invest and empower the young people.
Okay. Well, with what Anne has said, you cannot plan for the young people without the young people. So if you're a young person within the areas of Nakawa, within Makindye, and also within Kawempe, you can be able, if you have a smartphone or access to a smartphone, try using the Google contraceptive maps and see if you might be able to get access. If there's any issue, you can also raise it, because this is simply a pilot, so you can see what might need to change here and there. From our panelists, thank you so much for joining us this evening and sharing. I'm Rita Kanya, and from us to you, have a good evening. Coming up is The Bit.